Thank you, Dr. Vijay Mathur. Moving on to the next session, I would like to invite on stage Dr. Gauri Diwan, Consultant Developmental Pediatrician at Sangat, New Delhi, Dr. Lim Ming, and Dr. Michael Chevel to chair the next session. Dr. Michael Chevel is a chair of Department of Pediatrics, McGill Faculty of Medicine and Pediatrician in Chief, Montreal Children's Hospital at the McGill University of Health Center, Canada. Dr. Lim Ming is the consultant and reader in pediatric neurology at Evelina London Children's Hospital, UK.
Hi, good afternoon. Should we be starting? Crack on. Yeah. Okay. So good afternoon, everybody. And I know it's a long afternoon, but hopefully everybody's going to wake up for this very interesting session. We first got Dr. Pratibha Singhi. She's currently the Director of Pediatric Neurology at Medanta, New Delhi. She was the former professor and chief pediatric neurologist at the Neurodevelopmental Department of Pediatrics in PGIMER, Chandigarh. She's the elected secretary and executive board member of the International Child Neurology Association, and has more than 400 research papers and 4 books to her credit and name. So Dr. Singhi, we are really looking forward to hearing this session on early diagnosis of autism.
So good afternoon, everyone. May I have the screen connected? Thank you very much for the kind introduction. And once again, congrats to Dr. Gulati and her team for organizing this wonderful meeting. It's a very long afternoon indeed. And I don't know how many people will survive this without having a cup of tea. But nevertheless, I've been given the assignment to talk about early diagnosis of autism. And I'll try to just give you the important points on the slides so that we can finish in time. So the plan of my talk is simple: ASD and its prevalence. What's the importance and what are the clinical issues in early diagnosis? And I'll just briefly touch upon research in early diagnosis. You all know that now the DSM-5 is being used instead of the DSM-4. And I was just listening to someone from the West who was talking about psychiatrists and how they keep changing DSMs every now and then, and whether it really makes sense to do that. Nevertheless, it is proposed that modification of DSM-5 will possibly help ensure that ASD is identified accurately in young children. Is autism actually increasing, or is there a hype? There are, of course, increased awareness, increased training. So people have become much more tuned to making a diagnosis of autism. Earlier, children were referred to us with a diagnosis of mental retardation, speech delay, etc. But now they do keep coming with query autism. So the awareness has increased. But possibly there is also an increase, a true incidence increase in autism. And most of us who are in the field would see so many children with autism. A particularly peculiar thing, at least in India, being the child comes hooked onto the mobile. A little toddler comes looking at the mobile, and the moment the parents want to snatch that mobile from his hand, he goes haywire, throws a tantrum, starts throwing things around, etc., which is quite a familiar scene with most of the clinics. Why do we need to make an early diagnosis? By itself, it has no meaning unless it has some value. So it has been proven conclusively that early diagnosis leading to early intervention does lead to improvements in cognition, in reduction of abnormal behavior, acquisition of skills, reduction in secondary problems, and is very helpful for the parents to accept the problem and go on with it. However, there are certain issues in early diagnosis, and the diagnosis is often not made until 2 to 3 years after the symptoms are recognized by the parents. And mostly this is because of lack of awareness by the physicians or the pediatricians or the people they go to. However, as I said, the awareness is now increasing. There are certain challenges in early diagnosis because the symptoms themselves are not evident in general up to 12 to 18 months of age, because the child looks relatively normal until then. And in toddlers, stereotypies, the classic picture of autism in the public mind is of stereotypies and a child looking here and there, and that is not really seen in toddlers. We do know that autism is a spectrum, and it varies from mild to severe. So whether you are able to detect those as mild symptoms is another issue. And also that there are diverse developmental trajectories. So the onset patterns have been summarized as early onset, where you have low levels of social communication to start with, and the child remains that way. The other is, of course, the regressive type, which is very shocking for the parents because the child is growing normally and then loses the skills that he or she has acquired. And then there's a plateau trajectory, where the child is normal to start with, but then slows down and remains that way in social communication. The early features have been studied by many researchers, and we also have some of our studies in this field. And one of the important things is the gaze. The child seems to look through you. It's like a blank gaze, or will try to avoid contact. And sometimes, the child will look through the corner of his eye. These children are often suspected of being deaf, but if you ask the parents, they will tell you clearly that the child listens when he or she wants to listen, but if he or she doesn't want to listen, he will not listen. So, they may be suspected of being deaf, may not respond to their names, and ignore even very loud noises. On the other hand, they may be distressed by other types of loud noises. So they have this peculiar kind of contrast with noises. And then they may have fascination for particular sounds. And in general, if you ask these parents, the child is afraid of the sound of a cooker whistle or a mixer grinder or an engine, And sometimes they would love banging utensils, the steel utensils or a bolt on the door or something like that. Of course, there's lack of interest in reciprocal social interaction play, lack of sharing, and would not necessarily point out to things of interest. So we looked at toddlers with autism spectrum disorder who were less than 2 years. And the main salient features in these children were lack of speech. All of them were either mute or delayed, inability to follow verbal commands, lack of pretend play, no index finger pointing, and difficulty in playing with toys in a constructive manner. Lack of joint attention and motor stereotypies were the last, because these children are not so much into stereotypic behavior. Others have looked at the important early signs, and again, it's looking at others and orienting to their name that is most affected. And there is a paucity of gestural expression of interest and impairment of looking at faces, in addition to limited babbling. So the American Academy of Neurology has given these red flags, which of course are very helpful if you are not familiar with the topic, that does not babble or coo by 12 months, does not gesture by 12 months, doesn't say single words by 16 months, doesn't say 2-word phrases of his or her own by 24 months, and has any loss of language or social skill at any age. So obviously that you have to look at. And these are the children who have the so-called regressive variety of autism. And about a fourth to a third of children with autism will have this sort of regressive variety. So we looked at 35 children who had this sort of autistic regression, and the mean age of regression was generally around 22 months. And to cut a long story short, I would just say we did not find any significant differences in motor, social, self-help, and communication functioning between the two groups, the non-regressive and the regressive autism. Some other people have found some subtle differences. So how, if you make an early diagnosis, the fear is, are you making a correct diagnosis? Does it remain stable over a period of time? So to look at that, we studied 77 children prospectively in whom an ASD diagnosis was made at less than 3 years, and these children were followed up for beyond 4 to 5 years, and then they were assessed for autism. And the prominent social deficits in these young children included, again, the same as I mentioned earlier, which was non-responsiveness to social bids, poor eye contact, not smiling reciprocally, etc. And when we looked at these children later, we found that the diagnostic stability of an ASD diagnosis was very high, in fact 95.3, followed by an AD diagnosis, that is an autistic disorder, 89, and a low one for the PDD-NOS. Now the PDD-NOS is not recognized by DSM-5. This was when we used DSM-4. So it is all right if you are experienced enough to make a diagnosis. The diagnosis does stay stable over a period of time. There is a lot of research in early diagnosis. There are various markers that have been looked at, particularly behavioral and markers looking at siblings of children with autism who have been followed up right from the beginning. And most of these have found problems with eye gaze or with, sound, with being able to look at, faces. So more or less, this is where the research has led us to. How early can you make a diagnosis of autism? People have gone down to making a diagnosis of autism at birth and looked at the faces, etc. Now, I'm not saying you should do that. I'm just apprising you with what people are looking at. However, these studies still need validation, so I won't go into details of them. So of course, at 14 months and at 18 months, as I said, there are enough number of characteristics for you to suspect strongly that the child may have autistic spectrum disorder and to use the proper scales for evaluation. Again, others have looked at high-risk neonates, which means low birth weight babies with ultrasound evidence of ventricular enlargement, and found that these babies have specific continued visual preference for higher amounts of stimulation than the control infants. And they also have an impairment in disengagement. So it's not easy for the child to disengage from that stimulus. So they keep doing what they are doing. And they have sort of lack the typical developmental transitions in the visual system. And again, and these are summary of a number of studies, again, social impairment can be picked up at around 12 months. Poor eye contact, reduced social smiling, and then later comes the stereotypic or the self-stimulation expressions. A recent review has looked at and sort of summarized, and you can go through that review, that the early predictors can be looked at sensory motor development, where you may have reduced motor activity, you may have unusual mannerisms, atypical visual exploration of toys, and subtle motor delays. Deficits in attention, selective deficit in attentional disengagement, which I alluded to earlier, and difficulty in regulating their emotions. So, they are either too cuddly, or they are too detached, or too annoyed and angry, obsessive about things, etc. And in terms of social emotional development, there's a reduced positive affect. And then, of course, communication. There is a problem with communication. We all know that. Reduced babbling, reduplication. So these are some of the references. They are very nice review papers. How about genetics? The reason why I'm talking about genetics is everything is going the genetics way, as you heard in the morning. And if you have a family history of autism, it's very important that you look for signs and symptoms of autism in the child, because it is indeed a strongly heritable disorder, but the inheritance pattern is very complex. So we are not talking of something monogenic that, that gene will be in this child. But the recurrence risk is very high. In siblings, it's 20%. In monozygotic twins, it has been reported up to 99%, 30 to 99%. And in dizygotic twins, from 0 to 65%. More than 100 genes have been thought about as risk factors for autism. And as the point was being made in the morning, there might be certain, copy number variations which we are passing off as uncertain significance, but in a couple of our cases, we have found that somewhere in the world they have been reported to be associated with autism. So I won't go into the details of what is being looked at. Suffice it to say that there are morphological biomarkers. You know that some of these children have larger head circumferences and macrosomy. Subtle dysmorphism may be there, atypical facial symmetries. Neuroimaging patterns have been looked at, increased total brain volume. DTI has been looked at, some abnormalities have been found, and so forth, functional MRI, MRS, etc. And we'll leave it at that even EEG has been found to show some hypersynchrony. But as I said, this is all research, not yet validated, and so we should just keep our eyes and minds open to it. Some of the biochemical markers that have been repeatedly looked at are the blood 5-HT levels and decreased serum oxytocin, melatonin, and vitamin D levels, and of course immunological biomarkers, some oxidant stress biomarkers, and even mitochondrial biomarkers are being studied and have been found to be different from controls. Some of the established biomarkers include elevated blood serotonin levels and some excess of urinary solutes. This has been kind of replicated in a couple of studies. Head circumference above the 97th centile. To start with, it's normal, and then it increases, and then peaks at 6 months, 4 years, and then decelerates, and then at puberty, the head size seems to be normal. But this is not true for all children with autism. This is in some children with autism. So what do we do in the community? Now, it's easy for us to say screening at this level, this level, this level, but we have limited resources and a huge population to cater to, so it's not all that easy to actually do it on the ground level. But it has been found that training of pediatricians and other service providers goes a long way in early detection of autism. In fact, in a study, it increased the yield by up to 85% increase, which is great, really. So we must, try to train as much as possible, not just the poor ashas, but everyone else involved in the care of children. There are, advantages and disadvantages of early and late screening. Obviously, early screening means early intervention, but high-functioning autism and regressive types of autism may be missed. Late screening is obviously much more specific, but may miss on early intervention, so you have to find a balance. You have some general developmental screening tools, and you have autism-specific screening tools. So if you have concerns on general, go on to the specific tools. Lots of them are available. Most of you are familiar. I won't go into details of the screening tools. Future of early diagnosis, are we really going towards newborn screening? Remains to be seen. And automated diagnosis is also being considered. Computers are coming in a big way. So take-home messages. Parents' concerns about their child development should be considered seriously. Monitoring should be done properly. Red flags should be attended to. And of course, any early diagnosis is meaningless unless it is followed by early intervention. So with that, I'd just like to show a couple of videos and finish my presentation. So because some of the things that I talked about, so this is a young baby who, are we going to get the audio with it? So I don't think we are getting the audio. So actually the mother is calling the name I don't know, we are not getting the
साव्या सुनते क्यों नहीं हो
So,
आप?
so the child
बुला रही ना
seems
मैं
not
आपको,
to
इधर
hear.
आओ.
So appears like child is not
उठो
hearing.
उठो उठो.
Right? क्या करना? बस ठीक है, इसको तो हो गया. Next कर लें. I thought if I used my own computer, there won't be problems with the videos, but they have to be there sometimes. Disconnect हो गया. So this is what I was saying, that they may be obsessed with certain sounds, like, like this one. आप ही play कर दीजिए, क्योंकि फिर next कर दीजिए. ये next, ये वाला. And this is like, you're familiar that if you give them crayons, instead of using them, they would just line them. So. Next question. Next. So this is the typical spinning that
ऐसे
you see.
घूमता, ऐसे घूमता.
So the child would go on spinning either on
वो
his
भी
or her
मुंह में
own
ये डाल के
axis,
रखेगा.
or go around in circles. Next.
इसको इंटरेस्ट किस चीज़ में है? और कोई टॉय? खराब वाला मोबाइल. खराब हो चुके हैं वो दो. इसके हाथ में कुछ दे दो तो रखेगा. इसको इंटरेस्ट है, इसको डिस्ट्रैक्ट कर लो.
So this is another child. I think the voices of the previous one are getting mixed up, so I'm stopping that. And here you'll see that the child, you're calling the child, but the child is not responding at all, is continuing to just be obsessed with whatever he has in his hand.
पूरा दिन नहीं ना.
आगे चलाइए. हाँ, next.
पेशेंस भी लूज हो जाती है ना, वो एक आधा घंटा
So this is another child who is looking, but the moment you connect with his eyes, the child turns the face away. So, and then he's kind of trying to look through the corner of his eye. As I mentioned, sometimes they will try to look from the corner of their
क्यों
eye.
तोड़ा?
Next.
खराब हो गया, अब नहीं चलेगा. उठाओ.
So this is another one where the child would hold the hand of the caretaker, either the mother or the father, to point at objects. So, and first of all, they'll come and start rotating the stool in the clinic, and then he's asking the mother and the father to do that for him. And this is quite typical, that they'll hold the hand of the caretaker to do it. Next slide. Okay, I think it's just one or two more videos and I'm done. And this is what I was saying, like running around in circles.
The quality of energy inside. So this is how I was working before I came to the Brahma Kumaris.
So I think we'll stop there since we've run out of time. So thank you very much for your patient listening. Thank you. Any questions to be taken now? Or?
Yeah. Not coming up. Okay, there it is. Pratibha, when the DSM-5 came out, it sort of lumped a lot of different conditions under the autism spectrum disorder. And there was a great deal of disappointment by the Asperger community about being included. And I wonder if you can have any comment about that.
Yes, I know, particularly in the US, because the Asperger's was just removed from there. And all these children actually, needed special services which were denied to them because of the lack of the label. In India, it hasn't affected that much because, the services are not really provided that way. So people have not really bothered. You call them high-functioning autism, they are happy with that. But certainly in the US, it I think has made a huge difference. And you know, I made a light-hearted comment about the psychiatrists changing their DSM-5s. But this is true, that you know, things have been changed, and whether anything has improved after that remains to be seen.
Dr. Padit, just a quick comment for the rest of the crowd there. In our particular scenario, one of the early indicators we have said that the child should recognize their own name by 9 months to 1 year. The child should respond to the name. In our scenario, I normally tend to tell all the parents that they should choose one name. We have in our country a tendency to call the children by umpteen 4 or 5 names. So it becomes extremely one of the diagnostic clues which is missed. So one of the message would be that parents should start calling their children with a single name right from beginning.
Yeah, at least when you're testing them, use the familiar name. So yeah. So I don't know how many people here have that, but you know, particularly Mike, this is to you. But we just see so much obsession of these babies with electronic gadgets, mobiles, iPads, what have you, remotes. They can play the YouTube like a 2.5-year-old child can take out a song from the YouTube to his or her liking, will not speak a word, will not look at you, will be roaming around in the clinic. I don't know if you have a similar experience. So I think the first thing I tell them is to, you know, get rid of the electronic gadget for the child. Nandini?
Fashionable in Bangalore, the parents will come and say, my child can speak. He knows how to say 1, 2, 3, 4 and A, B, C, D and can say rhymes. But he will not respond to name. He doesn't recognize name. Doesn't. So these rote skills of these children are very common. I'm sure is there a feature on this place too, that they'll say rhymes, they'll say 1, 2, 3, 4, 5, 6, 7, 8 and they, of course, they don't know meaning of what they're saying, but they do say this. Yes. Very, very typical.
Some of them would have those skills, particularly the so-called high-functioning ones, where the social relationships will be totally nil and the verbal ability may be very high. Or actually the mechanical abilities of these children, they can break the mobile into pieces and fix it back again. And one of the parents told me that his son, who was just about 5.5 years old, could, you know, guide him which camera to buy because he knew each and every detail of the cameras, you know. So it's amazing what skills they can have, the high-functioning ones. Of course, most of them are not high-functioning.
Diagnosis of autism probably is simple and straightforward. You suspect fit into the DSM-5 criteria, finish practically. Now the problem comes when autistic features are associated with other disorders, such as CPs or intellectual deficiency or other encephalopathies. They do have autistic features and very difficult many times to diagnose. It needs very, very skilled psychologist to apply the appropriate test specifically for those situations. Otherwise, diagnosis may be missed or they may be overdiagnosed. Well, certainly. I mean, I have not touched upon the so-called secondary autism, which is associated with neurological disorders, including Rett syndrome, tuberous sclerosis, Fragile X, and all that, because that's a different thing. I've just talked about primary autism. Certainly, there are children who have had, you know, HIEs and all these kind of neurological disorders, encephalopathies, who do have features of autism, but then they are not labeled as primary autism. They are the condition with kind of autism. So, I mean, I think you need a good psychologist even to diagnose primary autism, because I still find a dearth of people who are trained in this.
So I'm just going to request, because I think we're really running quite over time, if other questions, you know, to Dr. Singhi can be taken one-on-one over tea. Thank you so much. That was just really very interesting. I think partly because I think as a country we're going towards diagnosis, but what are we going to then intervene with? So I think that's the next question, is where are the interventions? But I'm just going to hand over to my colleague to introduce the next speaker.
The next speaker is Professor Newton, who has been introduced already. He holds two positions, both in Kenya and in Oxford. And whilst he's walking up, I would just like to reflect that he's one of my teachers in pediatric neurology. Whilst I was an impressionable SHO, which was a senior house officer at Great Ormond Street, he was the senior registrar, and he used to beat me in squash. Thank you, Charles.
I'm not quite sure if I did really beat you in squash, but anyway, that was some time ago. Is my presentation? It's not up there. Newton. It's not there. There we are. Yeah. Thank you. Yeah, that's right. So, good afternoon. Again, I'd like to thank the organizers for inviting me to speak. I was given the remit of the diagnosis of autism in low and middle income countries, and this is really based upon my experience in rural Kenya, where we've been working on autism for the last 18 years or so, and have been struggling with trying to get the diagnosis correct in that context. I am going to, the take-home messages of my talk, so I'm going to abbreviate the talk, mainly because we're way behind time. Secondly is because a lot of the things I was going to discuss have already been discussed by previous speakers. And so my take-home message is what are the tools that we would use of the diagnosis of autism in low and middle income countries, and this is really based upon my experience in rural Kenya, where we've been working on autism for the last 18 years or so, and have been struggling with trying to get the diagnosis correct in that context. I am going to, the take-home messages of my talk, so I'm going to abbreviate the talk, mainly because we're way behind time. Secondly is because a lot of the things I was going to discuss have already been discussed by previous speakers. And so my take-home message is what are the tools that we would use everyday activities, and that I think is when the diagnosis becomes important, particularly if the child can then use that diagnosis in order, or the family can use the diagnosis in order to access support. So you've already heard, traditionally we've always thought of autism as a triad, impaired social communication, which is really the hallmark of autism, impaired language, and repetitive behaviors. And as you heard from Professor Singhi, that the DSM-5 collapsed the first two components of this into one, and increased the sensory component into the second one. And these are all the different manifestations that are found in DSM-5. And in fact, we use this as part of our clinical screening, or as part of our clinical diagnosis in Kenya. And we have a checklist which we look at for all of these features and check to see how many of them are present. More recently, I think it was in March this year, the International Classification of Diseases, ICD-11, was published. And again, this was very much in conjunction with DSM-5, collapsing it into two main disorders, that is of impaired social communication and including language, and the repetitive behaviors. They again emphasize that the onset occurs normally during childhood, and the deficits are sufficiently severe to impair the everyday social functioning of these individuals. The intellectual abilities ranges quite considerably in this context. There are some inclusions, in particular the classical autistic, primary autistic disorder, and also some exclusions that have occurred as well. In the context of the instruments that are available to help with the diagnosis of autism, there are a number which are well recognized, but I just want to highlight the ADOS, the Autism Diagnostic Observation Schedule. Since this is an instrument which has been used quite extensively, particularly in North America, and is regarded as the gold standard for the diagnosis of autism in North America. We actually started adapting it for our use in Kenya, partly because we kept on having our grants refused from the North American institutions if we didn't use ADOS as our primary way of doing the diagnosis. we have had quite a lot of difficulty in adapting this. So, for example, one of the features is one of the scenarios that you use in the ADOS is a birthday party. In the community that I work in, no one celebrates birthday parties, and therefore we've had to adapt that into a bath time or into washing in order to do it. And of course, by adapting a tool, you're never quite sure whether the adaptation is actually moving the tool away from the original validity of the tool. And this is obviously an important consideration. More recently, there has been a very good systematic review by Stewart and Lee, who looked at screening tools for autism in low and middle income countries. And this is a long list of 18 tools that they have identified. But the problem was that there were significant difficulties in interpreting the data because of the study design, the lack of psychometrics, the lack of confirmation of the diagnosis in this context. And what the conclusions of this excellent systematic review suggested was that studies should report psychometric properties of the instruments with particularly details about how the patients or the children were recruited and the administration methods. And also that the cultural adaptation is particularly important in using qualitative as well as quantitative techniques to adapt the tools. And thirdly, that the local stakeholders should take an important role in this context. And this is certainly bears what we have found in our experience in Kenya. So there are a number of tools, and I'm going to briefly go through these because I'm really going to emphasize that I think you've already got a very good screening tool in the NDST to use within India and further afield. The Autism Behavior Checklist is often used. It's a wide age range. It's quite a long tool with 57 questions. The parent or the teacher may complete it. It takes about 10 to 20 minutes to administer, and it has some subscales in this context. The sensitivity is high, but not particularly high, and the specificity is 91%. More commonly used is the Childhood Autism Rating Scale. This is used throughout the world. It's used for younger children. It does take into consideration the intellectual disability. And as you can see, it has a wide range of subscales in which it can occur. It is shorter to use, 5 to 10 minutes, because it's only got 15 item scale. And it is used quite a lot in terms of busy clinical practices in terms of diagnosis. And this has been used in many different cultures around the world. It also has a specific questionnaire for parents, which has a very high sensitivity of 94% and a specificity of 85%. And again, it's a short scale that can be used within the clinical pediatric practice and has subscales which are useful in defining the phenotype of the autism. The MCHAT, the modified checklist for autism in toddlers, is for a much smaller age range. It has a 2-tier system with a 20 item, first of all, given to the parent or the caregiver, and then 20 item follow-up. Again, it's a short tool. It is often used in office practice in pediatrics. The sensitivity and specificity are particularly high in this context, but it doesn't give any information about the subscales, but it's found to be useful in this context. And then lastly, the social communication questionnaire, which was formerly called the Autism Screening Questionnaire, used for over 4-year-olds. It is a longer tool, 40-item one, but it still takes only less than 10 minutes to do, and it has a number of subscales. The sensitivity and specificity are not as good as some of the other scales which I've mentioned previously. And the reason I mention this is because we used this scale in the early 2000s to look at children who had been exposed to cerebral malaria, because we noticed that some of our children who had been exposed to cerebral malaria, particularly when they had cerebral malaria early on, had very autistic features. And the difficulty was that we found it quite a difficult tool to administer in this context. There were a number of questions which, in particular, didn't seem to discriminate between those who we felt clinically had autism and those who did have clinical autism. And this was partly due to cultural things. So, for example, in the culture that I work in, it is thought to be inappropriate for a child to look at an adult with direct eye contact. And of course, the child was scoring quite highly on this, despite the fact that they didn't actually have any other autistic features. So this was the results of our study, which we never published because we felt the tool was not exactly examining what we wanted it to do. And indeed, the top 2 scoring of the children on the autism screening questionnaire didn't actually have autism clinically. And we felt that this tool was not of terrible use in our context and has subsequently abandoned it. But the real thing I think that we learned from this is that initially we just translated the tool. We didn't do enough anthropological and community engagement to work out how the tool would function. And therefore, it's not surprising that that this tool was not successful or not useful in detecting autism in our context. But what I would like to talk about is the neurodevelopmental screening tool, which is a tool which is developed, which was initially based on the 10 questions questionnaire, which is a tool that most of us have used for looking at neurodisability in low and middle-income countries. The 10 questions questionnaire doesn't have any questions about autism. And so Professor Aurora and colleagues expanded this to include a tool which has 39 questions, which includes quite a number of questions about autism and attention deficit disorders. And these are some of the differences that occurred in this context. So the reliability, or the internal consistency, I should say, of this tool is good, particularly for autism, with a Cronbach's alpha of 0.8, but also with some of the other measures as well. And it's shown to have good inter-rater reliability in the context of the studies that are conducted in India, which actually Professor Gulati alluded to earlier on this morning. We've used the tool in Kenya, and we found it quite useful in terms of detecting the neurodevelopmental disorders. But so we all found it to be very sensitive in the context of neurodevelopmental disorders, but it wasn't very specific. And therefore, you screened a lot of children who actually didn't have what we just defined as neurodevelopmental disorders as a result of this tool. The tool is linked in with the Inklen diagnostic tool, which again has shown to have to be particularly useful in this context, with a very high sensitivity and specificity when compared to the CARS tool and also to the DSM-5 rating as administered by a trained psychologist. And therefore, I think that these tools are actually particularly important and particularly relevant not only to India, but also other parts of Southeast Asia and also of many places or many situations within sub-Saharan Africa as well. And therefore, I think that these are the tools that we should be promoting in the context of trying to make the diagnosis or helping us make the diagnosis of autism in lower middle-income countries. But again, I would emphasize that going back to the DSM-5 or the ICD-11 criteria are particularly important because, after all, autism is a clinical diagnosis, and it does mean that you should be examining taking the thorough history from the parents and examining the child and observing the child thoroughly. These are some of the tools which have been used in Asia, which from the systematic review, which I've already alluded to. And as you can see, the sensitivity and specificity are quite high for the CARS in particular, and for the ABC as well, depending upon the cutoff point. So there are other tools available, but I don't think that they add anything more to the NDST tools as well. I was also given the remit of talking a little bit about genetics as part of this talk. And so for the last couple of slides, I'm just going to mention that, although there was a very thorough discussion of the genetics earlier on this morning, and I don't really have that much to add. Simply, I wanted to emphasize the fact that although autism is a highly heritable condition, and probably there are now over 300 genes linked to autism, of which about 65 appear to be more strongly linked to autism. In fact, it is only the ASD-related syndromes, which are diagnostic syndromes, which probably account for 10%, and then rare chromosomal abnormalities, which account for a further 5%, which are particularly important in clinically. The difficulty with the rare copy number variants or the rare penetrant genes is that it's very hard to counsel a parent when you get these results, because the significance of them, as Professor Singhi has already alluded to, is difficult. So this is a schema that is used, which has been proposed in the United Kingdom in order to try and simplify the whether you should be genetically testing patients with autism. It's divided up into those with complex ASD, those who've got dysmorphic features, abnormal growth, or other medical complications such as epilepsy, and those who are essentially are primary ASD. And those who have primary ASD, chromosomal microarray, particularly for Fragile X, and MECP2 testing for Rett syndrome are probably the only really essential investigations. For those that don't, are part of complex ASD, then probably a referral to geneticists, if there's the one available, for more further investigations are particularly important. The counselling currently is that if you've got a child with autism, the reported risk of having another child, if the first child is female, is about 7%, and it's 4% if the first child is male. But if you've got multiple, then it goes right up to 35 to 50%. And this is a schema which was developed by the American Genetics Society, again emphasizing that it's important to get a full family history in order to particularly try and get 3 generations worth, look for dysmorphic features, and if there are clinical features to suggest for metabolic or mitochondrial testing. Otherwise, to use chromosomal microarray, genomic hybridization, and single nuclear polyamide SNP polymorphism arrays as well. And also not forget for Fragile X. The second tier is particularly if is in females with ASD, looking for the genes associated with Rett syndrome, and also if the phenotype is suggestive in males. And then using the phosphatase tensin homolog disorders if the head circumference is greater than 2.5 standard deviations. These are a number of the syndromes, which are clinical syndromes, which would, if the child had those features, should prompt specific screening for those in particular. So, in conclusion, autism is a clinical diagnosis, and we still use the DSM-5 and or the ICD-11 criteria. The screening tools are useful, but need to be adapted for the local settings. I would suggest that the NDST, the neurodevelopment screening tool, and the inter-ASD appear to have good psychometric properties in India, and perhaps should be the first choice, particularly in the context of India. And that the genetics of autism is complicated, rapidly evolving, and it's often quite hard to provide advice to parents in this regard. And then lastly, I'd just like to remind you about the ICNA conference, which is going to happen in Mumbai in November, just in case you've forgotten about it. Thank you very much.
Thank you. Open to questions, Professor Singhi. Is there 2 mics? We can walk the next mic over there at the same time. Oh, yeah.
No, let Pratibha go first.
Thanks, Charles, for beautifully summarizing all that. I was just wondering, have you found difficulties in using the cars in the so-called low middle income countries?
So I must admit, we didn't elect to use the cars because of the limited group of patients that we have in the context. So I actually don't have any experience of it. I do have some colleagues who down in Dar es Salaam in Tanzania who use it quite frequently, and they find it quite useful in this context. They haven't done any psychometric properties within their context, so I can't really talk to or answer your question within the sub-Saharan Africa context.
Because I mean, we find it like quite, friendly.
Yeah, I
in
know.
the sense, and it is
Yeah.
established psychometric
Yeah.
properties. So, and basically, it's not really a culture specific.
Yeah.
So it's
No.
kind of culture.
No, that's
free
what
as
my
well.
colleagues in Tanzania say as well. Yeah.
Why do you think the risk of autism is higher if the first child is a girl versus the first child is a boy?
I think it's just to do with the sex ratio, that, autism occurs probably more commonly in boys than girls, or I think there's quite a lot of issues about, underdiagnosing autism, particularly in girls. And I think that's how it relates in the context, that if you've got a girl with autism, then they probably have a more severe form of autism. They've got to get their features in order to get a diagnosis of autism, means that they have more pronounced features than boys often do, because they're able to compensate or camouflage a lot of the symptoms in that context. And I think that's just what the reflection is.
Thank you.
Now it's on. Based on your experience, which diagnostic testing would you do in the field for the rapid assessment of children with an autism spectrum disorder in a low or middle income resource setting?
So do you mean in the field where I work, which is in compounds with no walls and such like? Or?
That's right.
Right, okay. So what we essentially do is we assess the child for autism, and then we divide them into those that which follow the framework in the UK of a complex autism. So if they have dysmorphic features in particular, or if they have underlying other neurological deficits, then we take them in for much more investigations, and we try and support the parents in terms of investigations, particularly imaging, some genetic testing that we have available, and also make sure that we're not missing any metabolic underlying causes. But by and large, we don't do a lot of investigations in children with autism within the context that I'm working with in rural Kenya.
Okay.
Okay.
Thank you. So we're not swapping chairs yet. We've got a slight change in program, as I understand it. Someone's got to go and catch a plane. So we're going to have Dr. Samir Bashki up next. And he's the professor. You've got to get a flight as well.
Many people have flights to catch, yeah.
Yeah.
I think I also want to catch a flight.
Yeah. So he's a professor of Department of Medical Oncology from AIMS, and he's telling us about the ethics of clinical trials. Thank you.
Good evening, everybody. Can I have my presentation? So in the next 10 to 12 minutes, I'll take you through the ethics of clinical trials. I'm not a neurologist, I'm an oncologist, so I don't deal with the brain, but I'm sure that what I'm going to tell you, most of you in the audience do trials, and I'll update you with some of the recent things that has been updated with regard to ethics. I've been a member of the ethics committee now for last 5 years and have been the member secretary for 3 years. So I am essentially going to share with you the day-to-day problems that we encounter in these submissions. And hopefully after my talk, when you submit next time to your respective ethics committee, things might get smoothened out for you. So I just want to give you a glimpse of the success rate of the submitted projects. 99.5% of the projects submitted to our ethics committee get passed. But what happens is that in the first meeting, only around 20% of the projects get passed. And I hope that after this meeting, when you submit your project to your ethics committee, this 20% figure for you should come to at least 50 or 60%. When we make a comment in the first meeting, by and large, the remaining projects get passed. And by and large, less than 1% of the projects do not get passed because of a serious ethical problem. This data is of around 7 months of our own ethics committee. The schema of my presentation would be as follows. I will touch upon the components of an ethics submission, the key points, how to minimize getting queries after an ethics submission, true ethical issues, which I believe are not very common, at least at the place where I work. What are the rules for investigator-driven studies? Let's come to the components of projects to be addressed. Project-specific. I want to remind everybody that when we receive a project from any other specialty, we do not belong to that. I have to review a neurology project, an oncology project, and gastroenterology, and likewise many others. It's like a review meeting. The others may not know about your project as much as you do. Therefore, make it simple and clear for those who do not know your subject, understand it well. Address all the points as are mentioned in the guidelines. So my first point is simple and clear in simple language that a person who doesn't belong to your specialty also understands. True unethical issues are rare, which I have already said, but some things which often come up are conflicts of interest, and I am going to talk about that in the next few slides. Different trials, when you submit, require different set of permissions. Please ensure that your permissions are attached with your submission, and I will go through those as well. I want to show before you two titles, and I want you to make a judgment for your own self which one is easily understandable. This is the first title. You may just read it in the next 5 seconds. And I am now going to show the next title, which is this. When we reviewed these two titles in our ethics committee, our conclusion was that the second title appears more understandable. So make the title easy. Some of the common questions or the common comments that come to the investigators are, please make the patient information sheet in layman language. And let me tell you that as a member of the ethics committee, the first thing that I read of a submission is the patient information sheet. And I say that if I am a physician and if I don't understand that patient information sheet, I wonder how a non-medical person is going to understand. So make it simple. That's sure. So please spend time on the patient information sheet. Please submit as per your institute format. Mention the amount of blood. Don't say 10 ml, 20 ml, picograms. People don't understand picograms and ml. Express it in terms of teaspoons. Ensure that the PIS is adequately converted to the local language as well of that state. A requirement, please add the telephone number of the PI, which often gets missed. The PIs cannot be, we are going to do a study on X number of patients. The person who's going to participate is not bothered. You have to address the subject as you. It cannot be in third person. And for children, obviously, you have to address the legally acceptable representative. We need an assent form for children above 7 years as well. Please add that. we need to have a separate PIS if you are planning to enroll control subjects. We can't be addressing the control as you are diagnosed with epilepsy, so we need to take 1 teaspoon of blood. They are normal, healthy controls if you need so. With respect to questionnaires, which I believe many neurology studies do have that as a part of their submissions, you must have the permission letters to use the questionnaire or mention clearly that they are available in the free domain and do not require permission. A lot of the questionnaires may be in English, and please see if you have the Hindi questionnaire or the local language questionnaire, and add on if that has been validated in that language or not. If that is not available, that should be part of your submission. Obviously, we need clear outcome variables and how you would de-identify the data. And we need a case record form. Now, in the next 3 or 4 slides, I'm going to address true ethical concerns. Safety of intervention. My own experience is that amongst the submissions where a safety of intervention has been questioned is rare. Maybe 1 in 500 submissions, we would have questioned the safety of the intervention. But if it is 1, if you want to do an extra biopsy just for the sake of getting some information, would not be acceptable. Conflicts of interest. This often we get into a problem. We often face this problem. Let me give you a few examples. If I am doing, and I think I'll do one thing, I will give examples in the end as my slides go through. The third is sensitive questionnaires. We encounter this often in psychiatry, in the submissions from psychiatry. An example I'll tell you, somebody wanted to address or assess the depressive component of a lady who has delivered a preterm baby. And the questionnaires were almost 1 hour long. We in the ethics committee felt it was unethical to subject a lady who has just delivered a preterm baby to assess her depressive component by asking questions like how unhappy you are with your spouse, how unhappy you are with your family. We thought that was not ethical. Vulnerable population. Somebody who is blind or almost blind or has some other physical handicap and you want to do a study, unless it is justified, it would not be accepted. This is a vulnerable population. Failure to include genuine collaborators. You want to look at muscle biopsies, you have the information with you in your database, you have to have a pathologist on board. Common dissents when we write a comment to the investigator and some of the dissents that we get. Often we have to say that some of the drugs are being purchased by patient. These are not acceptable for the following reasons. So some of the dissents are, this is a post-marketing surveillance. It's a routinely used product even though it is a pharma-sponsored trial. If it is pharma-sponsored, if the investigator is going to get money for enrolling on the trial of a drug which is in market, then it has a conflict of interest. Because the investigator will tend to use that drug more often. So it's a conflict of interest. We would like that drug to be available free of cost to patients. The requirement for a new pharma drug is, for pharma trial, is a DCGI clearance, which is the Drug Controller General of India, an insurance coverage, and a registration in the clinical trials registry. Please ensure that there is no charge to patients. That is a requirement for a pharma-sponsored trial of a new drug. Now let me give you another heading, investigator-driven, but pharma-supported for existing drugs. DCGI clearance not needed. Drug should be provided free of cost to patient. Investigator-driven, pharma-supported. Now, investigator-driven trial of routinely used drugs. DCGI clearance not needed. CTRI registration needed. Free drugs not a mandate if it is a phase 3 of 2 existing drugs being routinely used for that indication. Let me tell you some conflicts of interest in the next 1 minute. Scenario 1. A tool has been developed for blood glucose estimation by a scientist at an engineering institute. Its validation has to be done by his or her spouse at a medical center. I think this involves a conflict of interest. If I am happy with my spouse, I am going to certify that instrument well. So I might as well not be the person to certify that instrument. So it's a conflict of interest. Scenario 2. As a program coordinator or as a faculty in my department in oncology, if I want to do a trial and want my residents to get enrolled into some program, some yoga program, which I'm doing as a study, there is a conflict of interest or a pressure on the vulnerable population, that is the residents. They might be under pressure to say yes to me and get enrolled. Not acceptable. Last, one more scenario. A pharma company approaches a physician to use a certain drug available in the hospital supplies, says that we'll provide you data managers to record the data. Please get the study conducted. Not acceptable. Conflicts of interest. My talk has ended now. If there are any questions, I'll be happy to answer.
So purpose of time, we're going to allow 2 short questions. Looks like one from the chair.
Having done a number of national studies, what has always staggered me is if I give a protocol to 10 different ethics committees, I get 10 different responses. And at the end of the day, I have 10 different consent forms that I have to manage. And no one had really looked at the consistency of ethics committees in terms of their review of clinical protocols. And I wonder if this is a peculiar Canadian issue, or have people experienced this all around the world? And it seems that every ethics committee had its own peculiar institutional culture with no consistency between criticism from one committee to the next. And I've gotten criticisms that are polar opposites from one committee and the next. I wonder if I've seen that here.
So I think your point is well taken, and to some extent this problem exists even in our country. But by and large, there are some rules which are laid down by a body, the ICMR, which is responsible for medical research in this country. And all ethics committees are governed by those rules. So to some extent, we have set rules, but every ethics committee will try and address those with some minor differences. I would say that if the PI is at a center in Mumbai and the PI in my institute is just collaborating with that and is the site PI, I would be more comfortable and would require the PI, the main PI site, to approve the study before I take it forward, because I would believe that at least the PI's ethics committee has gone through it in some detail.
Thank you. Last question.
Yes. Thank you for very clear ideas about ethics in the research projects. Lot of centers are now doing stem cell therapy, and I would like to know if there are any clear guidelines and rules regarding stem cell therapy, especially the neurological patients. They are doing it very well.
Okay, madam, you have asked a very controversial question. Actually, there is a stem cell ethics committee which is separate from the Institute Ethics Committee. The stem cell ethics committee actually looks after the aspects related to stem cells, and once that committee has passed the study, it comes to the Institute Ethics Committee for approval. So there are specific rules and regulations which I don't think I'm the best person to answer this. It's a very controversial question. I use a lot of stem cells, but that's for cancer treatment, but that's a routine mode of treatment. It is not investigational. And I do believe that in stem cells, when it is being used investigationally, there are a lot of issues. And I don't think I have the knowledge to answer that question adequately.
I note that there's a talk later on that perhaps will address some of that. So thank you.
Thank you.
And it's the end of the session. Thanks.